In my opinion, the most difficult part of treating leg spider veins is not patient selection, nor the injections, nor the aftercare. It's the initial consultation and the consent process. Why? Well, because these are pretty much standardized and you can have a protocol you can follow. But for the consent process, every patient is different and the consent process must be individualized. To consent your patient effectively, you need good communication skills, active listening skills, and accurate documentation. And let's be absolutely clear. Consent doesn't mean signing a form with a list of side effects and complications. No. Consent is a process, a dialogue between you and your patient. Now, the law has changed, in the UK at least. The information a patient should receive is no longer what you think is important. The information you must give needs to be everything your patient believes to be important to him or her. So let's dive in. And if you're a healthcare professional, be sure to stay to the end, where I will give you my number one piece of advice to get consent right. In this presentation, we're focusing on consultation, consent, and treatment planning. It's the critical bridge between patient assessment and actually treating your patient. Now, if you missed my video about patient selection, check out the links in the description below. In this video tutorial today, we will cover how to build trust, how to manage expectations, how to explain the risks properly, and how to document the consent process in a way that protects both you and your patient. Let's start with understanding what the consultation is really about. The consultation is where you establish your professional relationship with the patient. Now, this isn't a quick chat. You need approximately 45 minutes to an hour for most patients. And during this time, you're assessing the patient's suitability for microsclerotherapy, exploring their expectations, explaining the treatment process, answering questions, and completing the consent process. Now, if at the end of this 45-minute consultation, the patient still seems ambivalent about whether to proceed with treatment, then offer them a second appointment to address any remaining concerns. Remember, patients who request thread vein treatment often view this as purely cosmetic. They frequently expect perfection in a very short time, and they assume, rather than communicate, that you will deliver this. So your job is to uncover these hidden expectations and address them head on. So what does the patient need to understand before we proceed? Before you treat anyone, patients must receive clear information on several key points. First, an explanation of their condition, what telangiectasias and reticular veins actually are and why they've developed. Second, a discussion of all treatment options, including the option of no treatment at all. Third, and this is critical, a full description of the treatment process. You must emphasize that several sessions are usually required, spaced 6 to 12 weeks apart, and that the veins will look worse initially before they fade, and the outcome is improvement, not perfection. You should also explain post-treatment management, the need for review appointments, possible clot or coagulum removal, and the possible need for medical compression. Don't forget to discuss costs transparently. That's costs per session fees, how many sessions are likely to be needed, and the cost of compression stockings if you recommend them. Once patients understand the process, we move to formal consent. Consent is both a legal and ethical requirement. The GMC and NMC have clear guidance on this, and I strongly recommend you follow that guidance. I've put links in the description for you to read. You must give clear, detailed information about potential benefits and risks, and document this discussion in your case records. I also strongly recommend having patients sign a consent form as supporting evidence of the consent process. The consent form will record what has been discussed. The challenge in deciding which complications to discuss is quite a significant one. You don't want to overwhelm or frighten your patients, but UK legislation requires that you discuss risks a reasonable person in the patient's position would consider significant, and the risks that that particular patient in front of you deems significant. This means the consent process has to be tailored to each individual patient. A blanket standardized consent form just will not do. Given that many patients and doctors view microsclerotherapy as cosmetic with no physical health benefits, I believe rare but serious risks must be disclosed alongside common minor complications. Let's break down those complications into major and minor categories. Major complications are rare, but they are serious and patients have a right to know about. These include allergic reactions requiring emergency treatment or even ventilator support. There are a few reports of death following sclerotherapy. Cellulitis requiring admission to hospital and IV antibiotics. Pulmonary embolism requiring anticoagulation. Skin necrosis that may need surgical debridement or skin grafting. These are all major and serious complications you must discuss. Other major complications include intra-arterial injection causing major tissue loss or even amputation. Deep vein thrombosis requiring long-term anticoagulation. Transient ischemic attack or stroke ranging from temporary impairment to permanent disability, and there's also the possibility of permanent discoloration. Now, these are frightening to hear, and many specialists are reluctant to tell their patients about these things, but they are part of informed consent. Present them calmly, in context, and emphasize that serious complications are very rare. You might also want to add what special precautions or specialist training you have to avoid and mitigate these complications. Alongside the serious risks, patients do need to know about the much more common minor complications. Minor complications are much more common, and while not dangerous, they can affect patient satisfaction. These include temporary discoloration that resolves within 6 months, bruising, mild erythema lasting up to 2 weeks, and post-treatment pain that doesn't require any additional treatment. Also discuss superficial thrombophlebitis that may need analgesics for a couple of weeks. Discuss also telangiectatic matting, those fine new thread veins that may require additional treatment, but usually which resolve spontaneously. Also discuss contact allergy to any dressings you might use, incomplete vein clearance requiring further sessions. Discuss also migraine, aura. Discuss hyperpigmentation that usually resolves within 6 months. And also discuss temporary numbness and itching that may cause a skin rash from scratching. These are the realities of treatment, and patients who understand them in advance are far less likely to be dissatisfied. Managing expectations is perhaps the single most important part of your consultation. I believe that some degree of pigmentation is present after nearly every sclerotherapy treatment. In fact, some experts describe it as an expectation rather than a complication. I tell my patients that brown discoloration is the ghost outline of the successfully treated vein beneath. It rarely persists beyond 6 months. Excessive coagulum or clot formation is a risk factor for brown marks, and needle thrombectomy reduces the incidence of this side effect or complication. Matting, that formation of new very fine spider veins after microsclerotherapy, does occasionally occur, and fortunately it is self-limiting. Here you can see the matting after sclerotherapy close up and its resolution with time. In fact, most side effects and complications are self-limiting, and the best strategy is what I call phototherapy. See the patient regularly, show concern, and take clinical photographs regularly at each appointment to demonstrate improvement. Patients need a clear, realistic understanding of what microsclerotherapy can achieve. It's unlikely that telangiectasias and reticular veins will completely be eradicated. They won't disappear. After completion of treatment, patients can expect a 90% improvement, which is a realistic goal. And use your language very carefully. Talk about improvement, fading, making veins less obvious or less noticeable. Please avoid promising or guaranteeing results. Never use terms like cure, disappear, eradicate, or remove. Patients must also understand that this is a condition that recurs. It's not a failure of treatment, and that maintenance treatments may be needed in the future. The treatment itself is a process, often taking months to complete, and the veins will look worse initially. If you advise compression hosiery, tell your patient it's necessary to improve outcomes. But despite these limitations, the evidence suggests that vein treatment by microsclerotherapy genuinely improves the quality of life of your patients. Patients often tell me it allows them to wear different clothes, enjoy leisure activities they haven't enjoyed for years, and feel more confident in relationships. 95% of people treated are either pleased or very pleased with the outcome. In my opinion, clinical photography is a vital part of the clinical record when undertaking microsclerotherapy, and I advise all practitioners to develop a routine, a protocol for photography from the very first day they start this treatment. Photographs document the baseline appearance, they track progress, and they provide objective evidence if there's ever a dispute about outcomes. Photography also forms part of your own reflective practice. Reviewing your photographs over time will help you improve your technique and refine your patient selection. Make photography a habit. It protects you, it educates you, and it often reassures your patients when they can't remember how bad their veins looked before treatment started. Now let's talk about how you actually plan and structure the treatment. Successful microsclerotherapy depends on careful planning based on what you found during your initial assessment. The treatment process works by destroying the endothelium of the veins, which then heal by fibrosis and vein absorption over several weeks. During the interim, during the healing process, the veins may actually look worse before they begin to fade, and patients need to understand that treatment is staged. You will typically see them every 6 to 12 weeks, treating different areas or retreating areas as needed. Each session involves careful injection of sclerosant into telangiectasias and reticular veins, followed by compression therapy for some and a period of observation. Your treatment plan should identify which veins concern the patient most, which reticular veins are feeding those telangiectasias, and the order in which you'll address different areas. Document this plan and share it with the patient so they understand the journey ahead. Part of treatment planning is knowing when not to treat or when to refer to someone else. Unless you are a specialist phlebologist with access to duplex ultrasound, high-frequency ultrasound, and a whole range of imaging techniques, not every patient who enters your clinic should be treated. If your continuous wave Doppler screening showed reflux, or if there are obvious varicose veins or the patient is highly symptomatic, you may need to refer to a colleague for duplex imaging first. Treating thread veins in the presence of significant reflux can lead to poor results and may make the appearance of the thread veins you've just treated worse. In addition, if a patient has very unrealistic expectations, they want perfection in 2 weeks for an upcoming wedding, for For example, it's better to defer or decline treatment than to proceed and disappoint them, or make their veins look worse for that special occasion. If there are relative contraindications, such as reduced mobility, arterial insufficiency, or significant medical comorbidities, then be wary, seek a second opinion, or get in touch with their GP before you proceed. Knowing when to say not yet or no is just as important as knowing when to say yes. Patients are increasingly doing their own research online now, and they may ask you about alternatives to microsclerotherapy. They may have heard about something else which they think might be better. Common alternatives include intense pulsed light, transdermal laser, transdermal thermocoagulation, and cryolaser or cryosclerotherapy techniques. You need to be able to discuss these options in the context of the treatment you're proposing. The consensus in the phlebology literature is clear. Sclerotherapy is the best treatment for reticular veins and telangiectasias of the leg. It's the most versatile, the most cost-effective, and it works on nearly any vein anywhere. Other modalities have a role in specific situations, but for most patients with leg thread veins, microsclerotherapy remains the gold standard. Be confident in presenting this evidence to your patients. Finally, to build a successful and safe cosmetic vein practice, your consultation and consent processes must be thorough, documented, and, most importantly, patient-centered. Allow 45 to 60 minutes per consultation. Explore and manage expectations actively. Uncover what the patient really wants and explain what you can realistically deliver. Discuss both major and minor complications honestly, calmly and clearly, and document this discussion. Use a signed consent form as evidence of a consent process and evidence of what was discussed. Incorporate clinical photography as a routine part of your practice at every consultation and plan your treatment systematically, stage by stage, and know when to refer, when to defer, and when to say no. When you get the consultation right, you protect yourself legally, you build patient trust, and you set the foundation for excellent clinical outcomes and a profitable, low-stress practice. Now, at the beginning, I said I would give you my top tip for getting consent right, and here it is. Don't treat on the same day as the consultation. Why? Well, because there's a lot of information to take in, and booking treatment on a subsequent day is evidence that your patient has had sufficient time to consider the risks and benefits and has been consented adequately by you. Now, of course, there are exceptions, and you may have had a preliminary consultation by video. Your patient may have shared photographs of the problems in advance, and your patient may have filled in a detailed questionnaire before attending your clinic. But in general, I would suggest avoid see and treat on the same day. Now, I hope you found this video helpful. If you did, please consider giving it a like and sharing it. It really does help my channel, and it helps spread the word about microsclerotherapy. And don't forget to subscribe. That way you won't miss my next video. Thank you for watching.